effectively. See a number of you joining us now. My name is Alistair Ager. I'm probably going to hand over to Khoury, my colleague from COMAS in Freetown shortly, who's due to be chairing this session, but we have some connection difficulties with her. So we'll be connecting hopefully shortly with her. Otherwise, I will introduce our session today. This is the third of 4 sessions as part of our NIHR Research Unit on Health in Situations of Fragility Symposium, reporting on various elements of our work over the last 4 years. And this session is particularly focused on our lessons from work regarding mental health and broader psychosocial support. So I will just give another couple of minutes for more attendees to join us, and then I'll be taking you through our session today. So I'm delighted to see my colleague Khoury just appearing there. Delighted, Khoury, that you're able to join us. I can see your face, so hopefully we'll get audio in a moment.
Hi, Alistair.
Hi, Khoury. So great to have, great to have you with us. I'm going to hand over to you. I've just given a broad welcome on behalf of all of us in this research unit. With colleagues here in Edinburgh at Queen Margaret University Institute for Global Health and Development, but very much involved in collaboration with our colleagues at COMAS in Freetown, AUB in Beirut, and also other partners who'll be presenting today in terms of our work in this area on aspects of fragility and their impact on health provision. So Khoury, I'm going to hand over to you just to introduce the session and then go over to our first speaker.
Okay, good morning, everyone. Apologies for the slight delay. Technology failed me at the very last minute. So welcome again to the third session for the NIHR RUHF Symposium. And this one is about strengthening mental health and psychosocial support in settings of fragility. So we have quite a number of speakers lined up for this session. I just also want to draw your attention that we have a chat function and the Q&A function as well. So please utilize those to ask questions and to raise any additional points or make any contributions as the presentations are going on. But I'll kindly ask, we'll have a Q&A session at the end of, after we've heard from all of the speakers. So the first speaker I'd like to introduce this morning is Dr. Rebecca Horn from Queen Margaret University. So Rebecca is a senior research fellow at the Institute for Global Health and Development at Queen Margaret University. She is a psychologist with a background in forensic psychology. Her research is broadly related to psychosocial well-being in areas affected by conflict, displacement, or disaster, and she has worked extensively for humanitarian organizations. Her work has included managing psychosocial programs in refugee camps and supporting organizations to integrate community-based psychosocial approaches into their programs. So over to you, Rebecca. Thank you.
Thank you, Khoury. Yes, it's great to be with you today and have the opportunity to talk about the work we've been doing with Khoury and her colleagues in Sierra Leone on psychological distress. So I'm presenting today on behalf of the whole team that's been working on this from COMAS and from QMU. And we've had a really fantastic group of field researchers as well who've supported us through this process. And perhaps one or two of them are joining us today. I hope so. Okay, Julia, if we can go to the next slide, please. Thank you. So this process began couple of years ago, and it began with a stakeholders meeting where we discussed with people working in the mental health field in Sierra Leone what the needs were. We also conducted a scoping study to look at what other kind of research or general information was available about mental health in Sierra Leone. And it emerged from both of those sources that there was a general lack of evidence around the mental health needs in the general population within the country. Most of the research that had been done was in the context of emergency, particularly the civil war that took place in Sierra Leone and the Ebola outbreak, and also tended to focus on particular aspects of the population. So, for example, children recruited into armed groups. There was also, we saw a lack of appropriate measures for mental health and psychological distress in the Sierra Leone context. Very often tools were used which had been developed in other contexts, Western context often, and had not been validated, the validity and reliability had not been confirmed in Sierra Leone. So the results of this were that it was very difficult in Sierra Leone to assess mental health needs in any kind of meaningful way, which then in turn, of course, made it difficult to plan mental health support systems that met the needs of the general population, because we didn't really know what the needs of the general population were. And in addition, where there were efforts to strengthen mental health and psychosocial well-being, it's quite hard to evaluate what the effects of those were, because there was no meaningful tool to assess that. So that was the context in which we began this work. If we can go to the next slide, please, Julia. Thanks. So from that context, we developed this plan for the next couple of years of our work. It had 3 stages. The first stage was to try to understand what is mental health and what is psychological distress in Sierra Leone. How do people express those concepts? How do people experience psychological distress, and talk about it and understand it? That was necessary in order for us to communicate effectively, but also to develop tools, measurement tools, which were going to be appropriate for that context. So that led us on to the second stage, which was to develop or adapt or identify, we didn't know to begin with which of those it would be, but to find a measure of distress which fits with local understandings and make sure that it works effectively in the Sierra Leone context. That would then contribute to being able to assess the impact of different types of interventions to strengthen psychosocial well-being and mental health. In addition, it would lead us to the third stage of our work, which would be to use these tools to study the patterns of psychological distress across Sierra Leone. So we aim to conduct a national survey of mental health and psychological distress, which would then feed into planning for the relevant stakeholders in Sierra Leone. It contribute to their planning for how to support people experiencing mental health difficulties in the country. So that was the plan. If we can go to the next slide. This was our first outcome. So at the beginning of this process, we undertook a study in 5 different districts of Sierra Leone. First outcome of this was we wanted to understand what are the signs of distress that people experience and report and recognize in others in Sierra Leone. So we talked to community members, asking them not about themselves, but about in their community. Do you know someone who's experienced an event that has led to them having emotional problems? If so, tell us about that. How do you know they experienced those problems? What changes did you see in their thoughts, feelings, behavior? And we identified 30 different signs of distress through this process. We then took those to people who had particular knowledge of psychological distress in Sierra Leone. That was people, not people who were trained in mental health, but people who were regularly dealing with people in distress within their communities. So that is community leaders, traditional healers, religious leaders, those kinds of people. And we took these 30 signs to them and asked them, do you see these? How often do you see them? How do they tend to cluster together? Do you get being isolated often alongside any of these other signs of distress? So we went through that whole process in the early stages of our work, and through that we're able to identify a series of signs of distress that people, there was consensus, were commonly experienced within Sierra Leone. So let's go to the next, please. The second outcome of that first stage was to understand something about what people feel contributes to distress in the Sierra Leone context. As I mentioned, very often the research has focused on emergency events, particularly the war and the Ebola outbreak. And the assumption has been that those are the things that have the greatest contribution to psychological distress. In other contexts, it's been found that it tends to be the daily stressors which have a significant impact on psychological distress. So we wanted to just check that out. And we did a small study, not that small actually, we did a study to look at what do people say are the problems that they experience within their communities for women and for men. And this rather busy slide gives you an indication of the kinds of things people talked about at the individual level, but also family issues, community issues, and then social infrastructure type issues. So let's go to the next slide. And that brings us to our third outcome from this work, which was the tool. So if you remember our three main aims for this, the second aim was to develop a measure of psychological distress, which builds on local understandings of signs of distress. And that's what we did. We developed what we call the Sierra Leone Psychological Distress Scale. And I've got this continuum illustrated here because I wanted to just explain briefly that we were not here looking for diagnoses. We're not looking to see whether someone has got a form of distress which is severe enough to receive a diagnosis of depression, anxiety, any other kind of mental health disorder. But we want to see the whole range of signs of distress, ranging from the very early signs and possibly quite mild signs of distress, which often come and then go if people receive the appropriate support at that level, right the way through to the more chronic, progressive and severely disabling conditions. And we felt that it was important that our tool did this because in Sierra Leone, there's a relatively little capacity for responding to severe mental health disorders. So it's much more appropriate or much more helpful, I guess, in terms of mental health systems to try to identify signs of distress at an early stage so that they can be addressed before they become severe and possibly be addressed at a community level. So people would not need to go to clinics, they would not need to go to hospitals, or certainly not to see psychiatric specialists. But there are many things that can be, many forms of support which can be offered at a community level if we're able to identify the early signs of distress and support communities to provide the kind of interventions that might be helpful in terms of helping someone to recover from those early signs of distress and not deteriorate further. So we developed the Sierra Leone Psychological Distress Scale based on the 30 signs of distress identified at the earlier stage of the project. And that's a 25-item scale. But also, because we're not looking at diagnoses or cutoff points, we wanted to have another measure which would indicate for us how severe is this distress. So we accompanied the psychological distress scale with what we call a function scale, or a person's ability to carry out their daily tasks and how much that was affected by their experience of emotional psychological distress. So those were the two tools we developed. If we can go to the next slide, please. Thanks. That tool was then used. We did do an initial validation when we developed the tool, or let's say a check of the validity and reliability of the tool. So we were fairly confident that it was going to work in the way we hoped. And then we used it to conduct this third stage of our work, which was the National Survey of Psychological Distress. We did that last year, and the measures we used were the two that I've already mentioned, plus, you'll remember from that very busy slide that you saw, we also identified some of the factors or the things that contribute to psychological distress. So we also developed a measure which included those factors. To what extent are people experiencing these difficulties in their lives? So using those measures, we sampled 904 adults randomly across 5 districts. And we're working now on the outcomes of that. So as you can imagine, we have a lot of data. The whole thing got derailed by the COVID pandemic. So we collected the data later than expected, which was in October of last year. So now we're working on these 3 final outcomes, which is, firstly, we just want to confirm that this Sierra Leone psychological distress scale is meaningful, is useful, is valid and reliable in that context. It is, we found it is, thankfully, and we're going to now make that freely available so that anybody in Sierra Leone or working in that sort of context can use this tool, both to do an assessment of what the needs are in a particular context, also as a tool to evaluate the effectiveness of interventions designed to reduce psychological distress in that context. The second is that we now have some evidence on patterns of distress in Sierra Leone. We are currently writing that up, and we can share that then with the mental health stakeholders in the country. And that information, which is a general population, about the general population outside of an emergency context, really, that can then be used to plan mental health supports, which really meet the needs of the population. And then thirdly, we will have evidence, we do have evidence on factors which contribute to distress in Sierra Leone. So we of course don't want to just respond to mental health problems, we want to prevent them. So the national survey data, we think, can contribute to advocacy efforts within Sierra Leone. And there's a lot of really great work going on, particularly by the Mental Health Coalition of Sierra Leone, to advocate for mental health promotion and the prevention of distress. And so we think that this information around the fact, what we know contributes to psychological distress, can be used to support those advocacy efforts. So I think, is that my last slide? I think it is, isn't it? So I'll finish there. I think I've used my 10 minutes and hand back to Hadja, or is it Alistair? I saw something pop up in the chat, but I didn't. Okay.
I'm still here.
Oh, great.
Hopefully.
Well done,
Can you
Hadja.
hear me?
Yes, thank you.
Yes. Thank you very much, Rebecca. It's very interesting hearing the findings from this study that we've been undertaking in Sierra Leone, and it highlights the importance, especially in situations of fragility, to ensure that the work that you do actually speaks to an identified gap within the mental health and psychosocial supports in the context that you're working in, to ensure that the findings are context specific and fit for purpose.
I'm going to jump in there. So Hadja, I think we've lost your audio briefly, but just to echo very much your sentiment of being very proud of this work, both in terms of its rigor, but very much in terms of its relevance to context. Our plan is to keep going through the presentations, and we'll have opportunity for discussion of individual presentations and their interconnection later. So I want to now move on to the next presentation, which is from Noubani from the American University of Beirut, working with the Global Health Institute there. And Aya will be reporting on this collaboration. You can see from the screen with colleagues here at Queen Margaret and other colleagues at AUB, including Lilian Ganto and Shadi Salah. So over to you, Aya, for this presentation on mental health service delivery in Lebanon.
Thank you, Alistair. Hello, everyone. I'm very glad to connect again. So today I'm going to present the findings of our project on mental health that we have been working on for the past 3-4 years. I think that I'm having also a problem with the internet connection, so I might switch off the camera. So the project entitled Mental Health Service Delivery to Vulnerable Communities in Lebanon and on the Road to Person-Focused Care. The work is a collaborative work between the Global Health Institute research team at AUB and the research team at IGHD Queen Margaret University. Second slide, please. So starting with the burden of mental health in Lebanon, as we know that epidemiological data or the data that assesses the burden of mental health problems in Lebanon are scarce and they go back to the years of 2014. The available study that we have showed that 25% of a cohort of adults aged 18 years or older who have the age of 18 years or older have at least one disorder, and 10% had experienced more than one disorder. And the most prevalent diseases in Lebanon or mental health issues are anxiety, followed by mood disorders. Also, the findings of the studies that are available showed that minority of the people in Lebanon who suffers from mental distress go and seek help from professional care or access the health system, or there are delays in these in accessing the health system for mental health care. The next slide, please. So the whole project, we conducted 4 studies, and these studies aimed first to examine how the community members, including the Lebanese and Syrian refugees, as well as the primary healthcare professionals, how they perceive mental health and mental health problems. This one of our project's aims. Another thing is to understand how the dynamics of the help-seeking journey and the health-seeking behaviors, and to determine what are the barriers that are standing in the face of the patient who is seeking care and looking for help from a health professional, and also to determine what our health system's ability in Lebanon and its ability to address the burden of mental health issues, with the view to identify opportunities that might help us strengthen the mental health and psychosocial service implementation. Second slide, please. So we adopted different methodologies. Mainly they are mixed methods. We adopted the qualitative methods, including the semi-structured interviews. We also conducted a group model building workshops, which is very similar to a focus group discussions, where we bring together community members and also primary healthcare professionals in a room, and they did a set of activities for them to give us like a picture on what are the factors affecting mental well-being in Lebanon and the barrier that is standing behind their journey for seeking care, and as well as the barriers and challenges within the health system. We also conducted a study that's adopting the vignettes methodology. The vignettes methodology is a qualitative study where we presented case scenarios for healthcare professionals on a certain mental health condition for a patient, and followed by that there's a set of questions where we ask them about their decision-making process and how would they screen and deal with the patient if he was presented to their clinics. This is mainly the vignettes methodology. And the 4th one was a quantitative study adopting a scale that is called the RDAC, which is a revised depression attitude scale that measures the attitudes of healthcare professionals towards depression at the primary care. So these are the main methodology that were used in our project for the whole 3-4 years. Our 2 main population were community members. We included in our studies Syrian refugees as well as Lebanese hosts, and also primary healthcare professionals providing care at the primary care centers. Next slide, please. For the settings, we also selected 2 different fragile settings in Lebanon. I know after 2019, all of the Lebanese settings are now extremely fragile, but at the time being, we were including the two extremities, which is the Bekaa rural areas, which is highly fragile because of the highest percentage of hosting Syrian refugees, having highest poverty rates, and also a major need for health institutional support. And from the other side, Beirut, which is known to be the capital of Lebanon and hosting the lowest percentage of refugees and having very low poverty rates. The next slide, please. So the key findings, first of all, starting with the factors affecting the health-seeking behaviors, both the community members and the healthcare professionals were in agreement that social stigma and the taboo around mental health is still and remains a major barrier for seeking help and talking about mental health in Lebanon. And we were able to identify the diverse route for the health-seeking journey that the patient or the person suffering from distress adopts during his journey. And first of all, people always open up for their family and social circle, followed by different coping mechanisms. We identify the gender differences in adopting coping mechanisms, and some of them can be positive ones, such as physical activities, dietary habits, or negative ones, such as going to alcohol, drugs, or alcoholism. And the final route was accessing the health system and seeking professional care. For the next slide, please. So when also talking about the delay for accessing the health system in Lebanon for reaching and for seeking mental health care, we were able to identify the barrier that the community talked about, and they mainly were around the mistrust and the quality of the service. So there's a lack of trust in the ability of the provider to listen confidentially to the patient. This is one, and two is the ability of the specialist to treat. So there's a question mark on the trust issue and the quality of care in Lebanon when it comes to mental health. Two, the lack of awareness to the available mental health services in the region or in the area. And three, the limited availability, the actual availability of the mental health services, especially in the Bekaa region in Lebanon. For the next slide, here in this slide, we were able to identify the barriers that were talked about and explained by the healthcare professionals to have a person-focused care for the health system. So the three main barriers that were identified within the health system in Lebanon is the lack of availability of a coordinated and cohesive health management information system, which is mainly compromising the quality of care. So each time a patient is presenting to a clinic, he needs to repeat the whole history, medical history and mental health history for him to take the needed treatment. So this is compromising the quality of care. Two, we have limited availability of human resources that are specialized in mental health, and this is mainly was identified due to the limited training that is being provided for health professionals in mental health, and also to the limited resources when it comes to budget allocation for mental health. And the three, we have the limited service integration and coordination, which is also compromising the system's ability to address the mental health burden. So here we gave, here the healthcare providers gave the example of when a general practitioner was able to identify or screen a person with mental health, and he needs to refer to a psychologist or psychiatrist, then the patient is lost with the point of he doesn't have a focal point to go to. So there's a lack of coordination. On the other hand, we were able to identify facilitators that were given by the healthcare professionals that might strengthen our system's ability to give coordinated and integrated mental health care, and that the healthcare professionals are aware that physical and mental health are interrelated phenomena that should be treated coherently and in connection with each other. Also, healthcare professionals are very open to build the trust and to have a secure environment with the patient for them to be able to open up and talk about their mental health distress. And the third thing is that the healthcare professionals are not only concerned about the physical well-being of a patient, but they are caring about more other social factors and issues that might encounter the patient and that needs to be addressed. And that's why they raised the point that the importance of the healthcare professionals to be working in conjugation with social workers that might help them improve the well-being of a patient. For the next slide, please. Now, for the findings of our second study, where we adopted the quantitative scale that measured the attitudes toward depression, first of all of the healthcare providers that were part of this study mentioned that they come and encounter patients on a daily basis having mental health problems. We had 94% of those who participated in the study encountering these individuals. And healthcare professionals are in high agreement that primary healthcare professionals should be trained on to have the ability to screen and manage mental health cases. Now, this scale includes 3 different factors. The first one, the attitudes toward general perspectives and depression occurrence, recognition and management. We had positive attitudes toward this factor, and all of the majority of the respondents were agreeing that depression have care needs similar to other medical conditions. For the second factor, which is therapeutic optimism, this one we were able to highlight that their attitudes were neutral to negative towards the treatment and therapeutic outputs of depression. While the third factor, the professional confidence, where most of the healthcare professionals were neutral to positive. They feel comfortable when dealing with depressed patients. However, they feel more confident and relaxed while examining physical illness rather than mental illness due to the shortages and the trainings and the mental health aspect. For the second slide, Julia.
Sorry, I changed the slide. Do you mean this one?
Okay. No, not this one. There's another one. The previous one. Okay, we missed a slide. Okay, I'm going to add also key findings where we were able to identify that the better attitudes were among healthcare professionals providing care in Beirut, and among those who were trained on the MHGAP. MHGAP is a WHO module that trains healthcare professionals at primary care on screening, managing, and detecting depression and mental health issues at the primary care setting. So these scores and attitudes were higher among these professionals. Now, for the findings of our third study, which is the vignettes, which helped us in determining the decision-making process of primary healthcare professionals, we were able to identify that the general practitioners and psychologists spend really long time on reading the case in order to understand it more than the caseworkers and the nurses, while GPs and nurses also, they are the ones that spend more time in the decision-making process, unlike the psychologists and caseworkers. Also for the actual rating of the cases, the GPs and caseworkers had the rating in line with the actual severity of the case. And there is always adoption of referral to psychiatrists and social workers, as well coinciding with the increase in the case of the severity. As a conclusion, so the overall architecture of, we can conclude from this study that the overall architecture of the health system in Lebanon is geared more toward the physical health and on providing patient-centered care rather than person-focused care. And there's so many limitations at the health systems level and challenges when it comes to resources and availability of specialists. Yet the healthcare professionals were able to illustrate their willingness of to be more engaged into integrated person-focused care and to give more of a community level support. Now, our final conclusion and recommendation that we need a concrete and more coordinated effort, and maybe further investments are required in Lebanon for us to improve the mental health services at the health systems level and to improve the burden of mental ill health in Lebanon. Thank you. I'm going to hand over to Haja.
Thank you very much, Aya. Can you hear me?
Yes.
Yes. All right. Thank you very much, Aya. Very interesting study. And I think it highlights the fact that we need to have more of these types of dialogues at all levels, so we can break this cycle of stigmatization when it comes to talk about mental health and psychosocial support, and also to move more towards a person-focused care, which is holistic, that takes into account both physical and the psychosocial side of things as well. So many thanks. Next, I'm going to move to the next presentation. And we have 3 speakers giving that presentation. We have Dr. Sabrina Hermosilla from Columbia University, Professor Pike, also from Columbia University, and Dr. Brigitte Khoury from American University of Beirut, who are going to be sharing their findings as well. So over to you. Thank you.
Thanks very much. It's a pleasure to join you, and I will start us off so we can go to the first slide. So our study focused on education and health in fragile settings. We know that formal educational systems are mandated to provide the academic preparation necessary for individuals in society. But our question really is, then, how does that work in a fragile context? They play a central role in the organization of and access to services for children in other contexts, children and families, particularly around health screening, health services, including mental health. And the question that we were investigating is, within the fragile context, particularly in the context of political instability and dislocation, where access to formal education is threatened, what role can schools play? What roles do schools play? And how can we understand that in the context of Lebanon? So looking at our educational systems, the mandate is to provide academic preparation. Functionally, they also serve to provide access to health and social services. In the social context, what is the potential for the school structure, school systems to do that? And how, with migrant affected communities, do they experience the school engagement, and what is the opportunity and threats in terms of school engagement? Next slide. So there are 2 key questions that we asked, 2 key areas of focus. Within the context that we were studying, fragile contexts have a depth of and key takeaways that I'm going to share to frame the study, and then my colleagues will go through the actual work that we did in the systematic review, the scoping review, and our in-depth focused group study. So key takeaways that we have are that within the fragile context, there's an enormous depth of local expertise that's not captured in the published literature. And we need to think very carefully and systematically and strategically about how to get those voices represented beyond the local context. That there are significant structural barriers to education and health. And next point. And that we have a key issue in managing and optimizing the engagement of the school system depends on flexibility, strong communication skills, and interdisciplinary teams for conducting research. Next slide. 2 key questions that we asked. What is the relationship between education and health among school-age children? And we know that we want to know what's been published and documented in peer-reviewed and gray literature in Lebanon since 2011. And secondly, what are the social connections that exist in terms of individuals, institutions, and organizations that school-age children in Lebanon identify as resources for addressing their health needs. and testing their instrument around social connection. So I'm going to turn the floor over to my colleague, Sabrina Hermosilla, who led the technical work around the scoping review to look at what we actually have in the published literature on this topic.
Great, thanks, Kathy. So as you mentioned, we conducted this scoping review to document state and local threats. And so we started by exploring 7 different databases for the peer review literature, but then also for the gray literature, explored organizational websites and expert outreach. Our inclusion criteria was very similar for both types of literature in that we wanted the similar publication dates. We started around 2011 because that's when the most recent flow from the Syrian conflict happened, and 2019 was when the study was conducted, when the search was conducted. We included literature in Arabic, English, and French around school-age children. We defined that as age 6 to 18 in Lebanon, and really needed the literature to include factors both on education and health, because we're really interested in this linking together, right? And our study team for this project had 9 different researchers and students from both Lebanon and the US, and we managed most of the process through Covidence, which was fabulous, and then used Google Forms to extract. And if you want to go to the what we found a little bit, yeah, so we explored on the left-hand side, and I know they're small, but from the peer review literature, we found over 4,000 citations, but after going through the steps, ended up with about 51. For the gray literature, and this is of course collapsed across all languages, we started with about 600 citations in the gray literature side, and you'll see a slightly different process because gray literatures don't have structured abstracts the way peer review do, and similarly came down to the 51. Next slide, please. So then what does the literature look like a bit? Not surprisingly, the darker bar here is the peer review, the lighter bar is gray, is the gray literature. Most of the studies were published in English, although we did include some in Arabic and French. Next one. And then when you look at it over time, similar to trends we see in publication elsewhere, that over time there's been an increase in publications in both the peer review and gray literature. Next slide. So after extracting all of the information and starting sort of a more analytic process, we wanted to have a way to visualize or conceptualize how these different factors were able to interconnect together. And so what we did was create this density map where each circle or node is proportional in size to the number of citations. This is really small. You probably can't see it. Can we go to the column? So I wanted to just pull out a little bit for us to look at. And so if you see violence in school, for example, this is pretty large. And so this represents 21 different citations in peer review or gray literature mentioned this factor of violence in schools. Then violence in school, all those connectors going out was connected to 9 other different factors. And then the weight of those lines is similarly proportional to how many citations reference that connection. So for example, there's a light color between violence in school going to substance use, more in the middle of the slide. And that was 3 citations, 3 different citations referenced that, whereas the thicker ones presented more. And this gives us a graphic way of trying to see what is actually published, what connections are published, what's actually there in the literature. Next slide. So understanding that there are some challenges to the literature and it's not perhaps as complete as we wanted, before we even started this, we proposed that we wanted to go back to the stakeholders. We wanted to go back to local academic partners, people who are working in the government, in the ministries of health and education, and nonprofit actors, and say, okay, this is what we're seeing in the published literature. How does this track with what you know to be true, what you see every day, right? And so we did this through key informant interviews that happened very recently. So these are sort of our preliminary conceptual understanding of their responses to what we found in the literature and the gaps. So the first thing we found were some synergies between the published literature and stakeholders. And so one of those has to do with, you can just do all of these, I'm sorry, I animated this too much, thanks. With preventing, one of the primary synergies is around preventing school dropout. There's quite a bit of literature around how to prevent school dropout and how to therefore improve the downstream, both educational and health effects of that. Similarly, there's a lot around violence in communities and schools and a little bit in the homes. And then both in the literature and in the interviews, we saw a lot of discussion about these structural barriers. So legal status, for example, the Palestinian youth is seeing really a decreased excitement and engagement in educational activities because they don't have the potential, or at least appear or feel as if they don't have the potential for legal work afterwards. So to say another way, what's the point in going to school and studying if I'm not going to get any kind of different job afterwards, right? And so seeing the intersection of these sort of structural barriers on individual levels. And then there's insufficient support, both financial and political, for the schools. There is a lack of synergy between the curricula. So for example, for the more recently arrived populations from Syria, the school systems are very different. And so how do recently arrivees get into the school system and affect and realize positive outcomes? So then the second big primary area of takeaway are issues or themes that the stakeholders really emphasize and we did not see in the literature. And so we have seen some of these in sort of outside of Lebanon, broader, sort of, if you're familiar with these sort of studies, broader thematic understanding, but is really absent in the literature within Lebanon itself. So the first one is child marriage. And so it's a little bit in the literature, but it's not as prominently featured as it was with the key informant interviews. This was really something that was seen as an urgent issue that needed to be addressed. And second, which is still sort of surprises me how absent this is in the literature, there's basically no discussion on the home environment, no discussion on parents' background, parents' education, the stress and challenges on parents, and then the physical environment, the overcrowding, the lack of privacy, this entire understanding of the home environment and the influence on children's educational health outcomes is completely absent in the literature. Next slide. So that's essentially it, the brief on the scoping review, and that sought to answer the question about what in the documented relationship between education and health among school-age children. And so now I'm going to pass it on to our third presenter, Dr. Khoury, to speak to the next question.
Thank you, Sabrina. If we can move on to the next. Okay, so the second question that we investigated is basically what are the social connections that children identify as resources whenever they have any health needs. And that ranged from individual people to institutions, NGOs, organizations. So we next slide, please. So we ran some focus groups. I will walk you through a bit the methodology. So we had 7 focus groups done in the Noubani camp. It's a Palestinian camp that has been established over 30, 40 years ago a bit out of Beirut, in the northern part outside Beirut. And what's particular about this camp is that it's a camp that actually has mixed religions. It's Christian and Muslim, and has Palestinians as well as Lebanese, as well as Syrian refugees more recently. So we had an easier access to the camp because I know the director of the schools that are housed in different Palestinian camps. And that one was actually a bit easier for us to access, whether distance-wise, whether also security-wise. So it was ideal for the research team to be there. So we ran 7 groups. We had groups with children, age 11, 14, and 15 to 17, Lebanese and Palestinian, and then parents who are also Lebanese and Palestinian. Then we had another set of 3 groups with Syrian refugees, similarly 2 children's groups, children and adolescents, and then a 3rd one with parents. And then we had a providers and teachers group, which was mixed nationalities. Now, I want to pause here and mention that many of these nationalities actually were mixed. We had Palestinians married to Lebanese, Syrian married to Palestinians, Syrian married to Lebanese. So, and they would always mention that yes, I'm Syrian, but I'm married to a Lebanese, or I'm Palestinian and I'm married to a Syrian. So the division somehow wasn't that clear in terms of ethnicity or nationality, but it was more in relation to how long actually had they been in the camp and how long had they been refugees. And of course, Syrian were more recently refugees as a refugee status in Lebanon than Palestinians who have been here for over 50 years. Okay, next slide, please. So one of the questions that I will show you as an example is, one of the things we ask them is, if you know a child who is struggling with anxiety, your child or a child, when we're asking teachers, struggling with anxiety, depression, feeling low, sad, considering self-harm, where do you go? What people or organization would you go to, or would you refer him to or talk to about such a problem? So we did the similar design called the PAT MSC, which is basically, they were just saying different resources, and then we asked them, what are the connections between these resources? So this is an example about mental health. So the graph on the right is in Arabic, and then you see it, next one, right, you see it in English, and the bottom one, it was translated. So basically, for example, they said, they would refer to psychiatrists outside the camp, outside GCC, the pediatrician, the neighbor, parent, school. And then the second level of questions was, okay, how are these connected to each other? Like the neighbors are connected to the children's friends and to the parents, or pediatrician connected to the psychiatrists or the parents or the school. And that was a way to see, who do they go to, but also how are these connected to each other? Next. So, of course, there are many, many challenges that exist when we do research in fragile contexts. And we had, of course, several challenges, which I think exist pretty much everywhere. Lebanon was a bit more particular this year. So everywhere, I think there are problems in, remote communication, coordination, sometimes inconsistent policies or institutional policies. And also the infrastructure, of course, of a fragile state or a fragile environment poses many challenges. So in Lebanon, we had, some of you may know, we had pre-existing economic and political and social tensions that already had been arising since end of 2019 and continued. Then, so we had many strikes and many demonstrations and roadblocks, et cetera, et cetera. Then on top of this, we had COVID-19 coming and lockdown waves that sometimes extended 2 months and 6 weeks, where we couldn't actually access the camp. The schools were closed. It was not safe because of COVID-19. They didn't want any, groups gathering. Then we had the Beirut explosion, which also in August delayed, it was a tragedy to the country, but also delayed a lot of the work. And more recently, and I was telling yesterday, Sabrina and Kathy, in a way, I was so glad that we actually collected the data and finished just on time before, again, there were the problems in Palestine and Israel and Gaza in the last week, because that caused a lot of turmoil and demonstrations in the camps. And the Baye camp was one of them. It was actually on TV showing demonstrations and support. And there was a lot of turmoil, schools closed again. So we were just lucky enough to have finished the data collection, and unfortunately, the wave of violence erupted in Gaza. So these are really some of the challenges, of course, on top of everything that is logistics, the internet, the electricity, all these that made it difficult sometimes to have virtual online sessions. And I can tell you, actually, the first round of focus groups, we did them all online. And then we thought it was too difficult. So the second round, we had actually psychology graduate students who went to the camp and did the groups with the children on site, which were much, much better. So I would like, next slide, please. So despite all the challenges, I think it's important to also talk about the positives of doing research in fragile situations. And in the case of Lebanon, there is definitely a lot of local expertise, which often is not captured anywhere in the literature. and yet are very, very important and are drivers actually to improve health and mental health in the country. Of course, there are barriers to education and health, but again, these local expertise and are the ones who can make these changes. And if just to leave you with like, what is this recipe for success to do research in such challenging situations or contexts? So having connections and collaborations with local leadership is very important. Being flexible, very important. Our schedule kept changing literally every other night. So we had to, work with whatever is happening in the country. Being able to communicate the good and the bad and the positive and the negative, and seek help and support if need be, and having an interdisciplinary team that actually looked at the situation from all different angles. And and this is what was the richness of the study and the data that came out of it, is that really it's looking at it from different perspectives. I cannot emphasize enough the importance of having collaborations and connections that are local. And the perfect example is that the way we got access to the camp is because, again, I knew the director, who's the mother of my best friend, actually, who's the director of the camps, the school camps, and she gave us access. The stakeholders also, it was personal and professional connections that we can access them and participated in the study. So this is very, very important to do and to establish once you would like to do any research or any studies in fragile contexts. Thank you.
Thanks ever so much, Brigitte. I'm just seeing, I think Hadja was trying to speak there. Hadja, are you able to connect, or do you want me to just, thank you so much, Brigitte and Kathy and Sabrina, and a really great example of your collaboration as well as our collaboration with you. So really pleased with that. It looks like Hadja's still having some problems, so I'm just going to hand over to Margaret. Margaret Blau, who is going to act as our discussant. I just had a preview of the presentations, and just going to make some reflections to kick off our discussion. And while Margaret is speaking, just to encourage you all to either through the chat or through the Q&A function to post any questions or comments, which we can then put to the panel. Margaret, great to have you with us, and over to you.
Thank you, Alistair. It's a great honor and pleasure to be allowed to say a few words here today. First of all, congratulations to the team, or the teams actually, for all the work that you've done in the past years, and especially the last year must have been a real challenge to do what you were planning to do. And a big thank you to the speakers for their great and informative presentations today. There are several things I took away from those presentations. I will not mention all of them because that will take too much time from the discussion. But firstly, that to strengthen mental health and psychosocial support in settings of fragility, we must appreciate the many different factors that influence it. The presentation showed the need to contextualize mental health and to better understand the relationship of what is envisioned on the policy level and the reality on the ground. We saw how perceived needs, preferences, and health-seeking behavior of people from different groups and communities have similarities, but also vary. We saw that barriers for seeking support include stigma, lack of trust, lack of awareness, and lack of accessible services. And we also saw the need for a gendered approach. We learned from the last study on education and health that there's a lot of local knowledge and experience that is often not captured. And I'm sure it's not only in Lebanon, but in so many places of the world. I think we miss a lot of local knowledge and experience. It's very interesting to hear, and also very sad actually, that there's so little literature on the child marriage and influence of the home situation in the education study. The first presentation from Sierra Leone showed very well how important it is to adapt and validate measures to the local context. In that presentation, it was also mentioned that there's a lack of evidence around mental health needs outside of emergencies. And so it looks that there really is a need for more forecasting, more preparedness, and not just troubleshooting. So my main questions to the panelists, but maybe also to the audience, are how can we move forward? How are the results of these and also similar studies fed back to the policymakers, to healthcare providers, and to community actors? Rebecca showed in one of her first slides that there are plans for that in Sierra Leone. And other speakers also briefly mentioned the importance about the right connections. And it would be great to hear from you what needs to be done and what could be done to promote a better collaboration and coordination between different actors. Thank you.
Thank you so much, Margaret. That's really helpful. Hadja, do you want to? I'll come to panelists in a minute in turn. But do you want to make any comments before we do that, Hadja, or I think you're happy for me to flag otherwise? So let's thank you, Margaret, and let's perhaps go through the panelists in turn. And Rebecca, it might be you, but it also if Hadja can speak in terms of perhaps that first presentation of what next steps would be. And I know you've been in discussion with Hadja about that. And I think just to emphasize one thing that fits in with what Margaret was saying, a real sense that this involves health services, but it involves many other actors as well. And all of the presentations, I think, have made that point, and clearly latterly with the schools. So I'll come to you first, Rebecca, but if Hadja, you could probably chip in, I'm sure Rebecca would welcome that. Given this data now, we have some measures, we have some evidence, we have some ways of framing psychological distress. I'm particularly struck, Rebecca, with this sort of identifying of early symptoms rather than waiting for extended complex disease and this sort of thing. How can that be used, do you think, in terms of the services going forward?
Thank you. Hadja, are you able to speak? Because I think Hadja has already been in conversation with people at the Ministry of Health.
Hi, yes, I'm not sure how long I'm going to stay on connected. So I'm going to say what I have to say very quickly. So the approach that we have used in Sierra Leone is by having continued engagement with the mental health coordinator and the director of NCDs and mental health of the Ministry of Health. And that is to ensure that our findings are relevant and to ensure that what we're doing, it's of value to them. So it helps with the research uptake and the evidence into practice. So over a period of time, we've been updating them as to what we're doing, next steps, so on and so forth. We share outputs with them. And not just them, but also key stakeholders. So we're part of the mental health coalition that Rebecca mentioned about, and these are at the forefront of advocacy for mental health. We presented some of our findings at they have annual conferences that brings together local stakeholders active within the mental health space. So we've done that. We have a PhD candidate as well who's doing something else on mental health, and he has engaged with them as well. So it's just keeping them engage and being very strategic to ensure that our findings are relevant and the uptake process is effective, and we at the same time we're giving them ownership and leadership of the process. So they're taking the lead and we're just providing the support and evidence as and when it's needed from the system point of view and also from the advocacy side of things. Thank you.
Thanks ever so much,
Yeah.
Hadja. And I know what a lot of effort that is on your part in terms of that continual chivying with key actors within the ministry and elsewhere. Can I come to Aya? Again, I'm aware a lot of work with Dr. Shamay and others in terms of the mental health work in Lebanon. Do you want to comment on how you think the research can and has shaped and influenced strategy for mental health provision, Aya? You're muted.
Sorry, she's just on a call with the World Food, so she's not able to answer right now. Alistair, would you mind taking a different?
Okay, so let me come. and it might be any of the team, but Brigitte, you were talking latterly about the value of the contextualization of its work. So again, just maybe on behalf of the team, but I'm sure Sabrina and Kathy can chip in. Given this foundation of work, how do you see it being useful either for schools or for other actors within Lebanon at this time?
Yes, I'm sure Sabrina and Kathy have their input. I think it's having these results, actually, we can take them and carry them into the schools and the camps and say, look, this is what people said and this is what is needed. To me, the ultimate surprise, I must say, was the difference between the scoping review and what's actually needed. And that there is still such a discrepancy, which might explain actually why so many programs fail or are non-sustainable in these contexts. You know, people get funding, they have a program, it lasts 1 year and then it's gone. So maybe because, you know, the literature is not showing what the needs are, but also the needs are not expressed in the literature. And I think we need to close this gap from both sides. So definitely a first step is, you know, taking these results and showing them to the stakeholders and say, look, what can we do and how can we help in implementing them? Kathy and Sabrina, please chip in for this.
My addition, building on what Brigitte is saying, is based on our results, I've been wondering and would love to hear what other people's thoughts are about how we elevate the knowledge, the local knowledge, in a way that increases its impact, not really its connection to the global academic research community, because at the moment there's a bit of a monopoly or a hierarchy of knowing. And so when it comes through in the published literature, there is a weight that is given to that form of knowing that is privileged over the local knowledge. And I think we're losing opportunity there and potential. And so I've been thinking, as we do this work as global researchers, how do we really optimize the benefits of the global knowledge and the local expertise more effectively? Because I think if we can unleash that and find that right balance between, we don't want people reinventing the wheel in every single camp, in every single village, in every single school setting, right? That's enormously inefficient. We don't want a different questionnaire or survey for every single study. So we do need to figure out how we go from the local knowledge and leverage the global expertise. The global knowledge and local knowledge dynamic is what's really on my mind, and would love to hear what other people think about that.
Thanks so much, Kathy. I'm going to link in Rebecca again in a minute, because I'm sure Rebecca would have a thought on that. But Sabrina, do you want to add anything particularly in the context of your study regarding that point?
Yeah, I think I was listening to both Brigitte and Kathy, and one of the sort of themes that I've been trying to pull out a little bit more, and you saw it featured prominently in the presentation, is also, I feel like we've been talking about genuine collaboration and working with local partners. I'm going to say 10 to 15 years. And I often find myself as a participant raising my hand being like, but how? How are you actually doing this? How is this actually happening? And I think one of the other sort of outcomes from this work as well is we have thought about this a lot. We've had COVID as an example for us to have very documented sort of stressors to these issues, like remote, all of our plans changing. And so I think something else we can provide for this project is in our case, this is how we did it, and these were the results, so that other folks can go, okay, how do we really, we're interested in starting a new study or continuing, or what are some ways that work for other people to help build these collaborations?
Thanks ever so much, Sabrina. So Rebecca, I'm going to come to you in a second. Oh, but what, right. So Karen, that's right, I can't answer the question. So do you want to, actually let me ask, I'll ask Rebecca this question, and then we'll come to, and encourage others to put Q&A in there, and then Karen can flag those to us. Rebecca, I wanted to come to you on that point, but really particularly linking it to what Kathy was saying about sort of the ways of capturing knowing. And I think obviously the strand of work that you've been leading with Hadja and others is very much about capturing local knowing about what's disturbing me, how I attribute the cause of that, how I want support. I'm just interested to hear a little bit about your story about how you've managed to protect that way of knowing within the global discussions, if you like, or both at a local level. And there's partly about getting it published, but I suppose I'm hinting at that even locally within ministries of health and high level discussions, there's a challenge of getting people to respect that local knowledge. It's not just about North and South, it's even within the context, protecting and promoting that local understanding seems to be something that your work has done in terms of capturing. So just a chance to elaborate a little bit on that.
Yeah, thank you, Alistair. I think, yes, I very much agree with what you've said. I think in many contexts, the medical model is privileged, isn't it? And diagnoses of mental health disorders are privileged. And I think that's, I mean, I'd be interested in Hadja's views on this, but I think that's also the case in Sierra Leone. You know, our work is really about strengthening supports for people affected by mental health problems or psychological distress, as we've called it. And certainly the connections that COMAS have got, and which have been very important with the Ministry of Health in terms of making use of our research, are crucial. But I think we've not been able to engage as much with the others, the Ministry of Social Welfare, for example, and people from that angle, the community angle. And I think that's partly because people don't see necessarily their role in providing support for people with mental health problems. That people with these early signs of distress are not seen really as having mental health problems. It's seen more as a kind of failure to adapt, a failure to cope with certain life events and so on. And it's really only when people demonstrate the severe signs of distress that people get involved. So I think it's something that we just need to continue emphasizing. And the good thing is, I guess, that there's become an increasing body of work around this. So it's no longer a case of having to just keep on being a voice in the wilderness, but there's a whole body of work behind us, and there's a lot of support now for this community-based approach to strengthening psychosocial well-being and mental health. Organisations like IOM and so on have produced materials to help with that community-based approach, and begin by promoting good mental health at community level, preventing the development of severe mental health disorders at community level. And then that frees up, of course, the people with specialist mental health skills to really support those who are in need. And there'll always be a proportion who do need that sort of service. But the more that we can emphasize and advocate for community-based approaches, the fewer people will develop the sort of severe distress, which does need specialist support.
Thanks, Rebecca. And I just wanted to mention, Hadja had reflected on it, say, Jawab's work, who's a doctoral candidate with us, looking at perinatal mood disorder, if you want to give it a clinical label, but basically women in distress in pregnancy or early lactation phase, and very much looking at early interventions with community resources as part of that. So it's an exciting part of work. Karen, can I come to you? You said that there's a Q&A so that I can't see, I think.
Sorry, there's not actually a question as far as I can see. We just have a hand up. So Hassan, I'm happy to allow you to ask the question if you're happy to. Oh, and we have Michelle O'Donnell. So maybe I'll go to, oh, no, we do not. Okay, we'll maybe go to Hassan first. I'm going to just allow you to go on.
Welcome, Hassan.
you should be able to unmute and speak if you like, or equally you could use the Q&A function.
Okay, while Hassan, so we're welcome to take your question, Hassan, either in the chat, as Karen said, or if you're able to unmute yourself.
Wilson's actually one of our research team, so
oh, great.
it'd be interesting to get his input. Yeah.
Maybe Hassan wanted to chip in on that. Hassan, we've got another 10 or 15 minutes, so if you're able to unmute yourself and contribute, we'd love to hear from you. In failing that, Brigitte, I think, put a hand up at one moment, but I actually wanted to ask a question partly related to some discussion in the chat, and it linked a little bit to what you were first saying, Kathy, is about the role of schools. And I suppose I'm struck with a dilemma of where, I think you're identifying schools as a place of great resource and knowledge, but also as a place of potential stress and demand. And I wondered, picking up on that in a way, I'd hate too many things to be dumped on schools. And I feel in many humanitarian contexts, there's, okay, this program is unsustainable as a short, but if the school teachers can do it, or they can do it in personal education, and a whole caboodle of additional burdens are laid upon a school. And yet your presentation suggested that there's quite a lot of capacity, quite a lot of resource. So I just wondered that balance you felt, and perhaps particularly from the school where you particularly focused in the camp, of that balance between resourcefulness and capacity and constraint, and how you saw that being addressed in seeing the school environment as one that could really promote health and well-being for youth and children in such a stressful time. So
thanks, Alistair. I'll provide a couple of comments, and then I'm sure Sabrina and Brigitte have further observations. My observation is that in general, schools, the teachers and administrators at schools operate with the subjective experience of feeling like they are at capacity. And so being asked to do more requires, I think, two things that Brigitte and Sabrina and I observed from our research. One is that the relationship issues are critical in terms of engaging school administrators and teachers. We talked yesterday a bit about the experience of trust, and foundationally that if the schools if the individuals, the decision makers at the schools have a high level of trust, that the work that's being asked of them to add to their routines will add value to their mission, that they often are able to find bandwidth, but that frequently the trust is low, and it really does depend on the relationships, as Brigitte was describing. And secondly, I think the capacity to convey that the research will help them do their job better is essential. That and we've all experienced this in the these studies and related studies around engaging an institution and institutional leaders like schools, that when the research needs to do the translation work of why the research matters in terms of advancing practice or policy that will help these individuals on the ground actually deliver on their mission better. So I think it's about a high level of trust in terms of network and relationship, and a level of trust around mission and purpose. Brigitte and Sabrina, do you want to add to that?
Yeah, as you were talking, Kathy, and from Alistair's question, I was thinking that I was pleasantly surprised to see the teachers and the health providers, the teachers particularly, quite sensitized actually to mental health issues. Whether they had training or not, I don't know, but they knew when there was a kid that needed help. Now, translating that into seeking help is a different story. And I think this is when the importance of the family and having parents on board along, so it's a team effort. And this is why the impact of the family and the household is so important, yet not researched at all. So having parents on board with the teachers to help the child with, of course, the proper referrals, et cetera, is, I think, what would lead to success. So this is the importance of the school, because they're the ones who see the problems first before getting into specialists, before even getting into primary healthcare. But then they talk to the parents, and then it stops there if the parents are not on board. So partly is, kind of bring up the awareness of the parents about these issues and sensitizing them also, and making it really a team effort for the benefit of the kids. And it's not, oh, we're complaining your child is hyperactive, do something about it. So I think that would be the right approach to, to get to somewhere. Sabrina?
Yeah, I mean, I think there's not much I can add to that. The only thing I'd like to underscore, basically, to one of your questions, Alistair, was universally, everybody in this context thinks that the schools are underfunded and undersupported. And so it is very true and very valid that too much is being put on these institutions and these schools, but that they're not shirking away from these responsibilities, but that is one of the few universals, is that there needs to be more support, both financial and legal and structural.
If I may add something, these are schools that are particularly dealing with a difficult, not difficult, with a population that went through difficult circumstances, so they know that they are going to be facing these problems. So they're not the regular schools in the cities. This is why I think there's a bit more sensitization. They understand where the kids have come from, the traumas they've been through, the difficulties, the parents, they know that. And this is why I think this is maybe the place to start, is in these school settings, in refugee settings or low-income community settings, deprived settings, and where we can really make a difference before getting into the whole governmental and regional or local policy system.
Thanks ever so much, all. And just to make a connection with the discussion that some people in this session were involved in yesterday regarding the discussion around fragility and trust. And Kathy, you raised that point there. And I think it's seen as so vital as a concept, both as a resource, but also as something that is fragile in fragile settings, both potential trust within communities and between communities and within institutions that either seem to be supportive or have let people down, and the state and so forth. So we had some interesting discussion, and Stella made this, I think, important presentation about the interplay of different forms of trust and how those can be cyclical, either developing trust and confidence within communities and institutions, or eroding that over time. So not now, probably, Sabrina, Brigitte, and Kathleen, but I'd be really interested in that little diagram that you drew of the connections of those that were the ones that were really trustful and really dependable, and the others that might be informational, but I wouldn't really want to share too much with them. I think deepening that analysis would be really interesting. We have a question or a comment from Clarissa Giebel. So Clarissa, thanks for sharing that. I think it's just a connection about this earlier point about connecting with community resources. Clarissa, if Karen can unmute you, I'm very happy for you just to reflect a little bit on that comment and the parallels with the other presentations. If you're not able to, Clarissa, that's fine, but it looks like, so Karen's enabled you. Are you able to just share your experience? I think you're working in Colombia and other projects. So if you can speak, Clarissa, please do so. If not, I'll summarize briefly what you were saying. So again, Clarissa, we have you highlighted on the screen, but at the moment you're still looked to be muted. If you can unmute yourself, we'd be happy to hear your voice. Otherwise, others can probably see it in the Q&A that Clarissa was sharing work in Colombia with local university there, and in the context of violence and COVID, looking at the mental health of older adults, and again, that importance of community engagement with local groups. And again, for those sorry, just a second.
Sorry, Alistair. Yeah, I see also a question here, two questions, one from Michelle O'Donnell. Can you see that?
Kathy, let's come to that in just a second. So for Clarissa's point, I think this connection between both formal mental health provision and community provision has been a major theme of yesterday and today in terms of presentation. So that's really important. Michelle, if actually, Kathy, if you can see it and I can't, do you either want to address it or
Sure.
That would be great.
So there's a question from Michelle O'Donnell about specific supports for school staff well-being, as they are also experiencing stress and distress in the fragile context. And her question, this too would contribute to trust. Well-being of each other is linked everyone's well-being in the community. And it resonates for me as a question and as an observation from work that I also did in the fragile context following the earthquake, tsunami, nuclear disaster in Japan, and the nursing staff being, of the community, but also providing care to the community. And so I think it's not only in Lebanon, but a really important general question. So Brigitte, I wonder if you want to speak to that based on your observations of our particular context.
Yeah, absolutely. I mean, you nailed it. The teachers and the health providers are also part of the community that is fragile sometimes, and they have their own challenges. And I agree, giving them an outlet where they can, share their concerns or their fatigue or their burnout is very important, and giving them the support. Sometimes, I think this came to the forefront with COVID nowadays, that, the health workers also need help and support. And now I think it's, it needs to be highlighted even more that we tend to take from teachers, but we rarely give them. And in such a setting, it is absolutely important to give them the support. I fully agree with you.
Okay, thanks ever so much. We're nearly wrapping up. I want to come back to you in actually a second, Brigitte, because there's a specific question from Hassan about your online focus groups. And I think you were glad that you did some that weren't online, but Hassan is interested to hear about your experience of that. And then after that, Brigitte, I'll just come back. I think Aya has had to go, but I'll come to Karen about any sort of final comment from the work that Aya was describing. And then I'll come back to the Columbia team with Brigitte for any final comment in terms of the work on schools. But first of all, Brigitte, this question of the online focus group discussions, would you ever do it again?
Yikes, no. If hopefully we don't have COVID anymore, we don't have to do anything online anymore. But it was challenging. I mean, the technicality of it was challenging. The electricity cuts and this and the online connection. I think Haja is suffering from it right now. So we had that. But also what we didn't pay attention to is that the age group of the kids, the younger ones, did not really lend itself to an online focus group. And the difference was immense is that the second round, when we did them in person, it was so much better. Although it was, recorded and everything, but it was so much better. They could connect better to the interviewers and talk more and be more at ease. So yeah, but ideally, I would just do them in person, absolutely, and not online.
Okay, thanks ever so much, Brigitte. So Karen, So I'll come back to you in a second, Sabrina, for a final comment. Because Karen, I wanted to link perhaps an opportunity to say anything regarding the work that I was describing, but also on this topic. I know that you've been engaged with colleagues at Gaziantep and others in terms of a sort of remote group model building, which is quite challenging. So just what your experience, maybe more positive experience than Brigitte, but just thoughts about remote data collection and particularly when we're committed to participatory work, then Brigitte raised an important point. It's so much more difficult to feel genuinely participatory in a virtual environment. So Karen.
Yeah, no, thank you. And I think I would echo Brigitte. It's very difficult. I hope we don't have to do it. I mean, if conditions must, then we will do it. It's very difficult also, I think, especially if I don't know if that was the case in your case, if the group knows each other and knows how to interact with one another, that's a first step. But then the second step is also putting them online. So in our case, that was particularly challenging. We had people who essentially represented donors who were not usually interacting and suddenly had to interact in this new way online with participation and everything. But it worked quite well, we found, surprisingly, with actually our health facility staff in Syria. So we had colleagues based in Lebanon, colleagues based in the UK, and then actual, managers of facilities from within Syria who connected on a day-to-day basis. So for them, it was just, okay, we're having another conversation, but it's online. It's a bit different, but we sort of get the gist of it. But certainly that made a huge difference, and we couldn't keep their attention for long. I think that was equally very, very difficult. Sorry, and on the work with Aya, you were saying?
Yeah, I suppose the final point, we didn't really hear in terms of next steps for AUB colleagues and also ourselves in terms of the uptake of that work or the influence of that work in the mental health strategy.
Yes, yeah, no, absolutely. So one of the key feedback feeding back, not just to the health facility staff that took part in our work, but equally also to the kind of national mental health program. There have been some presentations already with both kind of health professionals in the country, but equally with NGOs, and most of them in Arabic. So hence I'm not very, very familiar with all the content, but there was certainly quite a bit of interest, especially like Aya was saying, MHGAP had been introduced a while ago, or had been kind of introduced, if you like, as training had still been cascading through the country. And one of the interesting points was, again, when we looked at particular depression, anxiety, the more common, I would say, presentations at primary care, our health facility staff in some cases were still very confused about that, and equally confused about when do we call in help and other help, particularly social care. I think they really wanted to reach out. So that's been certainly an interesting learning for the mental health program. I know they reach out more routinely to these stakeholders, but particularly at those kind of points, now they saw, okay, there is but some more evidence, as we said, again, the primacy of evidence and what counts as evidence, but certainly they responded well to that.
Thanks ever so much, Karen. So we're wrapping up now, but I do want to come one last time to Rebecca, and then briefly to Kathy, Sabrina, and Brigitte. And perhaps I'll just put it as, in a sentence, that there are 40 odd participants, all interested in mental health, all interested in challenging environments. What's the one thing you would take from the bit of work you were describing that you'd want people to take away in terms of whether it's research or whether it's practice, policy relevance? What's one thing you'd like them to remember relating to the hour and a half they've spent with us? Rebecca.
I guess for me, it would be really about, it's a theme that goes through all of the presentations, about grounding services in the reality for people affected, whether that's staff in schools, staff in healthcare centres, or people living in communities. It's about grounding everything we do in that.
Okay, thanks so much, Rebecca. Kathy.
I would say honor the different forms of knowledge, because together networks get things done.
Thanks, Kathy. Sabrina.
Similar to that, I would say support and trust and the importance of local and international collaborations and really strong teams.
Okay. And finally, Brigitte.
What I would say is actually learn about the culture and the context that you're working in before you launch into anything. So first a learning process, and then, go ahead and do the work.
Okay, thanks so much to our presenters. Thanks to all the participants for your comments and the few questions that we've had. Just to clarify, this is the third of 4 sessions. A fourth and final session will be starting in half an hour, looking at the experience of the research unit and colleagues with respect particularly to COVID-19 and responses. So if you're able to join us in another 30 minutes, please do so. If you're not, it's been great having you with us. This has been recorded. All the materials will be available through the website. So we thank you for your time, and thank you again, the final time, for the presenters, not just for the presentations, but for the excellent work you know, both in terms of rigor and in terms of applied relevance that it represents. We're very thankful for your efforts. So thank you and bye-bye.